for joining in, and a special note of thanks to Dr. Jyoti Ramalingam for agreeing to do this presentation for us today, which is deeply appreciated, you sacrificing your Sunday for us to educate us on ECT. So, and before we start, I should also thank Dr. Devasmika Aryasinghe, Senior Lecturer in Psychiatry at the University of Peradeniya, for initiating this and organizing this event, and liaising with Dr. Jyoti Ramalingam and organizing this very important lecture on updates on ECT and guidelines on ECT, which will be very beneficial for our trainees as well as the psychiatrists working, already practicing psychiatrists in Sri Lanka. So let me briefly introduce Dr. Jyoti Ramalingam to the audience. Dr. Ramalingam is a consultant psychiatrist at Gosford Hospital in the Central Coast in New South Wales in Australia. He is a consultant in Consultant Liaisons of Psychiatry and a clinical director at the Barkly Vale Clinic in New South Wales. He is a fellow of the Royal Australian and New Zealand College of Psychiatrists, as well as a member of the Royal College of Psychiatrists in the UK. He is an accredited member of the Faculty of Psychiatry of Old Age, Faculty of Consultation Liaison Psychiatry, and he is the director of Electroconvulsive Therapy in Gosford and Wang hospitals. And he has published quite a range of articles, and mainly I'll be telling only about the articles on electroconvulsive therapy. A very interesting one on comparison of effectiveness of unilateral ultrabrief pulse and brief pulse ECT in older adults with depression, which was published in the International Psychogeriatrics Journal in 2016. And another on ultrabrief ECT for mania, which appeared in the Journal of ECT in 2016, and Clinical Alliance and Research in ECT Network, also in the Journal of ECT in 2017. And his special areas of interest are in mood disorders, anxiety disorders, treating psychiatric presentations in patients with neurological and medical comorbidities, and of course, electroconvulsive therapy. So the Sri Lanka College of Psychiatrists is in the process of formulating our own guidelines for electroconvulsive therapy, because all these years we have been following the UK or Australian guidelines for ECT, and now we have to make few changes with after considering the resources that we have in Sri Lanka. And so I think your presentation today will be very important, not only for the trainees in psychiatry in Sri Lanka, but also for the practicing psychiatrists to, it will help us to formulate our own guidelines. So Dr. Ramalingam will be talking to us today on the indications, the procedure, titration of doses of ECT, and the complications, of course. And so he will prefer if the questions are asked at the end of the presentation, but you may type your questions during this presentation as well, so that he can see your questions. Okay, thank you very much again, Dr. Jyoti Ramalingam, for agreeing to do this presentation for us, and which is great. And I think it's a very timely topic for us, especially as we are thinking of formulating our own guidelines for Sri Lanka. Thank you very much. And without further ado, I'll hand over to Dr. Jyoti Ramalingam to proceed with this presentation on ECT.
Thank you, Jihan. Hope you can see the presentation. And that's great.
Yes, we can.
Excellent. Thank you for the opportunity to be here with you all and discuss ECT. I just want to preface my talk by saying I'm a clinician, and most of my experiences in the sort of clinical aspects of ECT. So I would also want to acknowledge Professor Colleen Liu. She's a professor in neurostimulation at the University of New South Wales. She's kindly allowed me to use some of her slides from one of her presentations in this talk. And So in terms of the outline for the talk today, we'll briefly talk about, the history and the evolution of ECT, more so in the last sort of 20 years to where we are in terms of the current state of ECT practice, and the types of ECT and the evidence base around the different types of ECT, and focus on clinical aspects, which is what I believe would be most beneficial for you all. So I'm happy to elaborate on it if I missed any aspects in there. And cognitive issues, which are a relevant aspect of clinical management of a person undergoing ECT, EEG, as well, and its use in ECT, and mechanisms for map action. We'll talk about it briefly towards the end. It's just a place where we work, Gosford Hospital. We've got a lovely new building a couple of years ago. So what is ECT? I think it's an important question, particularly not so much now. It might be more important down the future, because there are a lot of emerging treatment modalities which actually cause seizures, and some of them, like magnetic stimulation therapy, magnetic seizure therapy, and some others use electrical current, but they don't necessarily cause convulsions or seizures. For example, TDCS or NET, which is a non-convulsive electrotherapy. And so in ECT, we administer, it's administered under an anesthetic. We give a muscle relaxant because the seizures propagate into the motor cortex, therefore causing a motor convulsion. And there is, during the procedure, we will, we are passing a single train of bidirectional electrical stimulus for a short duration up to a maximum of 8 seconds. So we'll just look at the brief, history of ECT. So how did we end up using, ECT? Where does this all come from? The idea of using an electrical current to, treat psychiatric disorders and symptoms of psychiatric disorders. So it sort of stems from the idea of biological antagonisms. And in the early 20th century, there's been reports of treatment of neurosyphilis, with malarial fevers. So there is this notion that people with a certain illness can be treated by another illness sort of idea. So Ladislas Meduna, a Hungarian neuropathologist, he observed lower concentration of glial cells in patients with dementia precox or schizophrenia, and conversely also saw that there was a higher concentration of glial cells in patients with epilepsy. And there were other associations that he noted. The patients with unremitting epilepsy had lower incidence of psychosis, and there was also relief from psychotic symptoms in patients with schizophrenia when they had a seizure, or in fact when they developed epilepsy itself. So then the idea was, okay, perhaps if we stimulate and induce seizures in patients with schizophrenia, perhaps that will improve the schizophrenia itself. So then the question is around how to induce it. So camphor injections were used, and after a few treatments, they seem to, one of the patients that was first used on, he miraculously improved, and in fact not only improved, he got well enough to leave the hospital, get back to work, and stay in the community after 4 years of being in hospital, which would have been such a exciting prospect to experience back in those days, where there was no hope at all for some of these patients who were in institutions. And then there were other treatments that were used to induce. I'm just struggling with the slides here. They're just going all over the place. So there were other methods were used, such as metrazole injections, and then inhalational agent fluorothil, which was used to induce seizures. So they were all demonstrated to be effective. So then the idea that, okay, perhaps why don't we use electricity itself to induce seizures? Because there was this notion of the brain functioning being mediated by electrical currents themselves. So Seraliti and Bini in Italy, they founded a way of safely inducing a seizure without arresting the heart, which they did in leading up to this, and a number of dogs were sort of killed in the process. And then that was shown to be quite effective as well. After a series of ECTs, it cured delirious mania in a patient, and he was again able to be discharged home and return back to his family. So then the issues around convulsion and musculoskeletal injuries was there, and the unpleasantness of being under paralysis without and being aware was dealt with anesthesia. So a combination of using anesthetic agent and muscle relaxant came on, and it was becoming a bit more acceptable treatment, therefore. But memory problems prevail. So that still is the biggest concern when we using ECT in modern day practice. So following on, psychoanalysis was dominant for a period of time, and medications came into use around 1950s. But then, while they were promising, there was suddenly a subgroup of patients who were not getting well enough or remaining treatment resistant. Just another photo of where we work, from near to where we work. So it's so what makes ECT effective? I think that's important to try and understand. So we know that chemical induced seizures were effective. So then there was this idea that seizures are necessary to improve patients' condition. And what about the cognitive impairment and memory problems? Is that because of the electrical stimulus itself? So then perhaps the idea was that induction of seizures is necessary, but one has to think about the electrical stimulus itself and how it is delivered to reduce the side effects. So the direction of exploration of how to refine ECT went in that direction of refining stimulus characteristics and electrode placement characteristics, because at that point people already knew that the higher the stimulus intensity, the worse the cognitive problems were. So the next sort of couple of decades was really focused on minimizing side effects, because people knew that it was quite an effective treatment. So before we sort of look into the ECT stimulus aspects further, I just want to sort of go through some basics around ECT stimulus itself. So sorry, this is probably not clear. I hope you can see that sort of the black sort of pulse line on the screen. So this is a representation of an electrical stimulus. So where we see this is a train itself. That's a duration. There's amplitude, the frequency, and it is a bidirectional current going in both directions. And this is the width of the pulse. And any charge that we deliver to a patient is a product of amplitude, frequency, and pulse width and duration. So the same, one of the aspects that was manipulated to improve the outcomes with the ECT was to reduce the pulse width to reduce cognitive side effects. So if you imagine this is 1 millisecond, there was a reduction to 0.3, which was what is called ultrabrief pulse width. And the people, the researchers were able to show that ultrabrief pulse width caused much lower cognitive side effects. And that was because ultrabrief pulse width was more close to physiological duration of depolarization. So even though even a wider pulse would have delivered a larger charge because of the increased pulse width, but without any meaningful benefit, because most of that charge will be delivered during the neuronal refractory period as opposed to during depolarization. So by reducing the pulse width, the efficiency of the current was improved. And some definitions really before we go further, so we're clear on what we're talking about. So when we're talking about seizure threshold, that refers to a minimum charge of electricity required to elicit a seizure on EEG. Because motor seizures are unreliable sometimes in patients when they're given a muscle relaxant. They might be too sensitive and you might not see any motor seizure at all, although there might be a cerebral seizure activity, which will be detected by EEG. And doses of ECT are these days are always calculated based on seizure threshold. And is this a familiar concept, seizure threshold and dosing according to that?
We actually don't determine the seizure threshold like you in Australia. What we usually do is we go by the age divided by 2.
Okay, age method.
Yeah.
Okay. All right. So we'll talk about why this is probably a better method as we go. I think because the seizure, for different types of electrode placements and pulse width, studies have demonstrated what are effective doses in relation to seizure threshold. So and doses are determined based on that. So I think that's why the concept of seizure threshold is important. And when I talked about pulse width, we classify pulse width as 2 types. A brief pulse width, which is anywhere above 0.5 up to 2 milliseconds. Most commonly used is 1 millisecond, and Dave told me that the Timertron machines what most of you use, and that will have it as a DGX, is what stands for the 1 millisecond pulse width. And Ultrabrief is anything less than 0.5, commonly used 0.3 and 0.25 milliseconds. So from 1990s onwards, there was a lot of work around electrode placement, the dosage of ECT, pulse width. How can we manipulate to make this make ECT more safe in terms of the cognitive side effect, because the effectiveness was was well proven by them. So really, these are the 3 electrode placement positions we routinely use, the 3 common types. And the first one on the left is a bitemporal. It's the same location both sides. So, and the center of the electrode sits at 3 centimeters above the midpoint, joining the tragus and the outer canthus. And the second one's a right unilateral, and where the temporal electrode placement stays as it is, but the other electrode will go on the 3 centimeters to the right of the vertex. And then bifrontal, we are placing the center of the electrode 5 centimeters from a line drawn vertically above from the outer canthus, which is parallel to the mid-sagittal line. So, I mean, the electrode placements does matter, depending on where we put the electrodes. The electrical field in the brain is very variable. So this is just a representation. A computational model was used to represent how different electrode placements stimulate different parts of the brain, and how that might impact outcome in terms of effectiveness and also cognitive side effects. So when we look at bilateral, which is bitemporal, in fact, so we see that there is much higher electrical field just over the temporal lobes there, and reasonable sort of frontal stimulation, and sort of diencephalic midline sort of structures, thalamus, hypothalamus sort of regions, and similarly we are also seeing medial temporal lobe structures as well. So this is where the side effects happen, because it's sort of the hippocampi are also stimulated strongly, Whereas in bifrontal, you get prominent frontal. The frontal and the diencephalic structure stimulations are thought to be, necessary for ECT's effectiveness. So with bifrontal, we're seeing, more sort of frontal, not so much, diencephalic, but to some extent, and but the medial temporal structures are spared. So it's cognitively a bit more sparing than bitemporal. And with the right unilateral, again, you're seeing less frontal again, and some sort of diencephalic structures, and the medial temporal lobes are spared, particularly on the left side. So again, more cognitive sparing, but this is perhaps why in the right unilateral, the dose in relation to seizure threshold should be very high. In fact, 6 times is what is shown to be equally effective as bilateral. So you get that sort of frontal stimulation with a higher dose. So from in 1987, there was this sort of study done by Sackeim. Sackeim and his group really, did a series of studies from 1987 onwards to 2008, 20 years, sort of really refining electrode placement, pulse width, and dosage, and all that. So whatever the next sort of few slides are really those sort of series of studies that they did. So the first study was really to see, is unilateral ECT effective compared to bilateral ECT, because if by avoiding direct stimulation over the left temporal lobes, the idea is to minimize the cognitive side effects. So right unilateral ECT, clearly they showed that was inferior, at the end of ECT, the depression scores were still high with unilateral patients. And then in 1993, they did a double-blind study. They had 4 groups here, had bilateral, low dose, which is 1.5 times the threshold, and high dose, 2.5 times the threshold, and unilateral ECT with 1.5 times the threshold and 2.5 times the threshold. So what they were able to show was that, compared to the low dose unilateral, the high dose unilateral was more effective, 43% improved compared to 17%. So, but although the bilateral group, did much better. So, but there was clearly a dose-related, response here with unilateral ECT. So they concluded increasing the electrical dosage increased the efficacy of right unilateral ECT, while still preserving some, cognitive side effects. So that was promising as far as dose-related, response goes. So they wanted to look at how can it be made equally effective? Can we increase the dose further? So then they looked at another study where they did unilateral 50% over the threshold, 150% over the threshold, and 500% over the threshold. Compared it with bilateral ECT, 150% above the threshold. So what they found was high dose right unilateral, which is 500% above, was equivalent to bilateral ECT. And not only that, bilateral ECT resulted in greater impairment than any dosage of unilateral. So even the high dose of unilateral ECT at 6 times the unilateral, 6 times the threshold with the right unilateral was equally effective, but less cognitive side effects compared to bilateral. So really, from this was quite a landmark study. This really established that if we're going to use unilateral ECT, we should use unilateral ECT at least 3 times, if not up to 6 times at the seizure threshold to get adequate treatment, but also preserving the cognitive function of the patient. So there were further developments. This time around, in 2008, they wanted to look at Ultrabrief ECT. So wanted to reduce the pulse width to see, can we make ECT more cognitive sparing while still keeping it equally effective. So the 4 groups were Ultrabrief unilateral, Ultrabrief bilateral, and brief unilateral, and brief bilateral. What they found was, except Ultrabrief bilateral for some reason, the other three groups did well, meaning unilateral Ultrabrief was as good as brief unilateral and brief bilateral. And cognitively, this is unilateral Ultrabrief. At the end of the acute course, there was a slight worsening compared to baseline, 0 being baseline, but that improved 2-month follow-up and at 6-month follow-up. The others are still sort of lagging, compared to their baseline, other groups, even at sort of 6-month follow-up. So this demonstrated that, okay, this might be the way to go. That unilateral Ultrabrief ECT is equally effective, much less cognitive side effects. Perhaps this is a new world of ECT. But life's not always straightforward and simple. There were other studies done with Ultrabrief unilateral ECT that showed that perhaps it was not all that effective compared to brief pulse ECT. So this is the meta-analysis that shows that brief pulse ECT is more effective than more efficacious than Ultrabrief ECT. And that there is a bit of a discordance between RCTs and in more other studies that were done in real world sort of settings, more effectiveness trials. But even those trials, they were able to still show that Ultrabrief ECT was much cognitively sparing. Scores on retrograde memory, antegrade memory, and general cognitive functioning were all much more preserved in patients in patient groups which received Ultrabrief ECT. So what about bifrontal? There was a study done by Kellner and his groups in 2006. They compared, these are all brief pulse width. They compared bitemporal, bifrontal, and unilateral. They were all equally effective. Remission rates were the same. There was no significant difference, and the cognitive outcomes were also the same. Interestingly enough, in all the groups. And but only other positive, interesting finding was that bitemporal ECT resulted in more rapid decline in symptoms. So meaning, if you had a quicker onset of action. So this is the current state of affairs, with ECT. So we don't have, ECT is not one thing. It's not a unitary kind of treatment. You have 3 types of electrode placements that have evidence for it, and there are 3 types of pulse widths that you can use. And within those electrode placements and pulse widths, one can choose to use low dose or high dose in relation to seizure threshold. Although not all of these combinations are effective. So what is effective? So if we look at bitemporal ECT with 1 millisecond pulse width, that's all. That is the gold standard. And that works faster, that works more reliably, but that also has the most cognitive side effects. And with 1 millisecond pulse width, again, bifrontal has been shown to be effective, and right unilateral has been shown to be effective. This 0.5 millisecond has not really been all that studied. There's more clinical evidence. In Europe and the UK, there are lots of clinical experience in using 0.5 millisecond. It's still less. It's more cognitive sparing and than 1 millisecond, even when it's used with the bitemporal electrode placement or bifrontal electrode placement. And again, 0.3 millisecond, which is Ultrabrief. Definitely we know right unilateral Ultrabrief works. Bifrontal, there was one study which showed, it's probably not as good as right unilateral for some reason. Maybe the doses used in the study for bifrontal were not that good. Again, bitemporal was shown to be ineffective in the Sackeim study, and there are no further studies that actually show that it is effective. So I would refrain from using this. So it's more of what we really said. When we're talking about these questionable efficacies, it's perhaps that the dose in response to the seizure threshold in the studies were not adequate. Perhaps as we reduce the pulse width, the dose shouldn't be 1.5 times for bitemporal and bifrontal. Perhaps it should be more 2.5 to 3 times the seizure threshold. And similarly, definitely this is what we do. Even with the 0.5 millisecond. We use pulse width, when we use pulse width of 0.5, we tend to use the treatment doses upwards of 1.5, sometimes 2.5 times to 3 times the seizure threshold, even with bitemporal 0.5 millisecond or bifrontal 0.5 millisecond, for it to be as effective as it can be. So we've got an idea of what sort of options we have in terms of ECT itself. We'll move to clinical aspects. So what are the indications for ECT? And look, the most common indication is major depression, and at least in the Western world. I know I'm originally from India, but I know from a lot of the psychiatrists who work there that it's commonly used for schizophrenia as well, although that's not a prevalent indication in the Western countries. And it's used definitely in chronic treatment-resistant schizophrenia, particularly even in the context of clozapine resistance. And sometimes used in manic episode, when there is treatment resistance, or when there is a need to sort of rapidly control the symptoms because of the patient's aggression or agitation levels. And definitely a clear indication, one of the clear indications is catatonia. Catatonia of any etiology really doesn't have to be associated with a psychiatric syndrome. And neuromalignant syndrome, Parkinson's disease definitely has benefits, not only with non-motor symptoms such as mood, but directly has an effect on motor symptoms as well. But although ECT has now really been not at all used, because the more availability of deep brain stimulation for patients with Parkinson's disease in places like here. And it can be used for intractable TLE or status that doesn't respond to pharmacotherapy. So when can we use ECT as a first line? I think that's something to always keep in mind. When we're working in sort of acute psychiatry, when you get a new admission with a sort of a severe depression, or catatonic depression or a psychotic depression, when can you first go for ECT as a first line? One obvious indication would be that a patient has previously responded well to ECT, 2 or 3 treatments or even 4 treatments, they've done well. Then it makes sense to go to that instead of starting pharmacotherapy and waiting for a number of weeks, during which time the patient condition might deteriorate, risks might deteriorate, increase as well. And previous resistance to pharmacotherapy, in the past, if there is established resistance, then pharmacotherapy resistance, with resistance in further trials are going to be less likely to be effective. Further trials of medications, as we know with for example, the STAR-D trial, where there was sort of increased resistance every further step they went. And psychotic depression, because of the nature of the condition, it's very distressing to the person who's suffering, and patients often refuse to eat and drink, in those sorts of settings, and there is nihilism, and not only that, the response is quite remarkable, with ECT. So there is good reason to use it as first line. And other sort of acute psychosis, delirious mania is another condition where ECT can be similarly very effective, like in in psychotic depression. And depression, when it is associated with the high risks, such as high risk of suicide, in a highly distressed sort of depressive states, and very poor oral intake, cause putting the patient at risk of malnutrition or dehydration. Okay, so when we decided about the idea of ECT for a particular patient, in terms of preparing the patient, the first thing is to medically evaluate the patient and screen for any risks or situations that might increase the risk of ECT. And because it is a condition, it is a procedure that requires an anesthetic, we need to do routine bloods in ECG, chest X-ray if required, and if a patient has COPD or any severe asthma, then we would look at getting a chest X-ray, more so from an anesthetic point of view and airway point of view. And specialist assessments might be appropriate for patients who have identified health comorbidities, things like coronary artery disease, if a patient has a pacemaker or has had uncontrolled hypertension, those sort of situations will require specialist assessments like cardiologists or other relevant specialties involved. And once we've evaluated the patient, and it's important to communicate those issues to the anesthetic team and the ECT team if it's different to your own team. And the next step in all of this is really psychoeducating the patient and the family, because there's a lot of poor understanding and poor portrayal of ECT, and there's a lot of stigma associated with ECT. All of those aspects need to be addressed, because if it isn't addressed, that can become a barrier to consent. And so it's important to have spend as much time as possible in addressing those concerns and explaining the risks and benefits really of ECT. What are the risks of the condition itself? If the patient's got psychotic depression, what are the risks if they're not treated? And what are the risks of treatment with ECT, and what are the likely benefits? So, and really having an open discussion about that is important, and what to expect. Whether you expect the patient to start eating in a week or so with ECT, whether the patient's likely to walk if he's in a catatonic state, and the interactions improving. What are the chances of getting back to work, and when that's likely to happen? So really having a clear discussion around the expectations around the outcomes, and we're talking about psychotropics. What needs to be stopped, what needs to be started, and medications that should be continued as well, like antihypertensives and bronchodilators and stuff like that. And the keeper and the patient should know really how long this is going to take, how many number of treatments they're going to need, and how long it's going to be a likely course and whatnot. And the need for ongoing treatment after the acute course, because sometimes patients can assume that depression is a one-off condition and might not see the need for ongoing treatment. So one of the important things to understand with ECT is really the cardiovascular changes, because a lot of the risk is mostly around this. And if this is addressed, a lot of the risk is addressed. So we see a pattern of cardiovascular change with the ECT stimulus. So when the stimulus is being delivered, there is a parasympathetic surge causing a sinus bradycardia, sometimes even an asystole, often an asystole. Prolonged asystole is a concern, but asystole is not uncommon, and hypotension. So the stimulus duration itself is up to a maximum of 8 seconds. So after that, the patient starts to have the seizure, and then with the seizure you get a sympathetic surge, and with that, all those effects are reversed. And in fact, it's a polar opposite. You see tachycardia, hypertension, blood pressures of over 200 systolic, but briefly, that lasts for less than a minute, and then it drops again. And then the following the seizure, there will be another sort of drop in heart rate and blood pressure. It is really the postictal period when cardiac complications arise, particularly arrhythmias. So it's important to have the patient monitored, a bit closely during that period. And there are cerebrovascular changes. There is certainly increase in intracranial pressure, intraocular pressure, and there is an increase in cerebral blood flow. I mean, these are concerns. If somebody has, for example, if there is an aneurysm or an AV malformation, and then the increase in blood pressure and intracranial pressures, all these things will matter, because one would be at risk of aneurysmal rupture. So this is just the ECG, that demonstrates what we just talked about. So this is just the ECG before treatment, and this is where the stimulus gets given, and you can see a pause in the ECG, and then after that, there is sort of normal activity, and then the pulse rate sort of picks up to a peak heart rate. And the asystole, so it's not the same with all types of ECT. So if we have a patient who has bradyarrhythmia or has a history of bradyarrhythmias, and then you're really desperately wanting to avoid any incidents with that, then we can do things that can reduce it, by varying the electrode placement and the pulse width. So we know that, looking at this, the bifrontal ECT has 2.5% incidence of asystole compared to right unilateral brief pulse, which is 49% incidence. It's nearly half the patients in that sort of sample group it was reported. So, if you're desperate to avoid such a change in cardiovascular function during ECT, then in a particular patient, then you might choose bifrontal ECT instead. Or if you have to use right unilateral, you might use ultrabrief ECT, because that's sort of half the incidence of right unilateral brief pulse. So it's just a representation of the phenomena we just talked about. So this is both both left and right. They're all right unilateral electrode placement. It's a representation of the electrical field and the stimulation in the brain. And with 1 millisecond pulse width, you see that there is a wider sort of area of electrical stimulation. The electrical field is wider, and you, more importantly, you see that there is a brainstem, is affected by this field. And whereas when you reduce the pulse with 0.6, it's quite not ultra brief, but still, the brainstem activation is absent. So this might be, why you are seeing less bradycardia with ultra brief ECT pulse width. So what are the high-risk situations? Any condition that increases the intracranial pressure would be a reason for concern. Cochlear implant, although there are multiple reports that say that it's safe to do ECT, both ipsilateral and contralateral electrode placements. Recent brain injury, infection, stroke, history of post-ECT delirium, and uncontrolled hypertension. Recent MI, although it's not a contraindication, the risk is elevated in the first 7 days after MI, and the risk is mostly around further infarction and sometimes myocardial injury, and unstable angina and poorly compensated heart failure. Heart disease, bradycardia, heart block. As you can see, it's mostly cardiovascular sort of scenarios. Cardiac pacemakers, although it's not a none of these are contraindications. When it comes to ECT high risk, we're talking about situations where we need to be aware and really closely liaise with the relevant specialists and the anesthetic team and have a plan to address the risks, if the benefits of ECT are so high in a particular patient. And vascular neurosystems, they're a concern, because of the risk of rupture, really. But because it's often an incidental finding, and I've certainly had patients who have had aneurysms who've been found to have aneurysms at a later stage, probably a couple of years or so later, but they've had ECT before that, but we just didn't know about it, whether it emerged in that time, it's hard to know, but if you know of an aneurysm in a particular patient, it would be very high risk unless it's coiled, and then you might be safe to proceed. And epilepsy, there's a small risk of inducing status epilepticus, but ECT itself has anticonvulsant properties and in fact raises the seizure threshold. So it is not a big concern as such. And osteoporosis increases risk of fracture, retinal detachment and glaucoma because of increased intraocular pressure. And the muscle relaxant use can also increase the intraocular pressure. And dentition, if there are loose, teeth or tooth, then it needs to be extracted. There is a real risk of aspiration should that, teeth dislodge, or if a patient has, particularly unusual sort of issues with their teeth, then they might need a special occlusive block during the ECT. And obesity, because of how it can affect respiration during an anesthetic, and skull defects, or any plates, titanium plates, and thromboembolic disease. And if there is a DVT, there is a risk of dislodging the embolus during ECT. Pregnancy is a relatively high risk situation. So we'll just talk about pregnancy and ECT just briefly. So again, in any situation, we're talking about risk benefit, and in this case, there is the additional dimension of the fetus, and so what are the risks to the fetus through the mental illness? If the patient's, if the mother's not able to look after their health well because of the mental illness, if the mother's not able to eat well, how does that affect the fetus? And also the risks of ECT for the fetus, and what are the benefits? And should the patient's condition improve, what are the benefits? So it's really sort of balancing all that, and that it is more important to have because there is another dimension to it in pregnancy. And in particular, for the fetus, the cardiac effects are from the anesthetic. There can be a cardiac suppression from the anesthetic agent, so that needs to be talked about, monitored with the cardiotocography during the procedure and also after the procedure as well. And there are certainly some risks reported around uterine contractions during ECT and the risk or increased risk of premature labor. So it should always be, in a sort of certain beyond the second trimester. One has to, do it in a setting where there is an obstetrician available. And there are some issues around positioning of patient to optimize in the fetal circulation, and that needs to be specifically considered. And medications for reflux must be taken to avoid the higher risk of aspiration in the pregnant woman. So general side effects from ECT, headaches are common after the procedure. It's managed with simple analgesia, paracetamol or ibuprofen. And muscle pain. Muscle pain is not because of the seizure itself, which is sometimes often misunderstood. And the muscle pain is a side effect of the muscle relaxant succinylcholine, and that can be the case. So, often educations around that's necessary. I've certainly had situations where patients wanted to withdraw consent for ECT because they had myalgia, and with some explanation they were able to be convinced into continuing the course of ECT. And again, that can be managed. If it's really severe, then you can talk to the anesthetist about using a non-depolarizing agent like rocuronium, but that just requires a reversal agent because it doesn't get metabolized. So nausea nausea from the anesthetic agent is also a sort of a common side effect, and the risk of oral injury or risk to the teeth itself. There can be dental fractures. So we should always use a proper splint or a mouth guard to really protect the dentition. Even though a muscle relaxant is given, when you've got a temporal electrode, there is a muscle relaxant only acts at the neuromuscular junction, and when we put the temporal electrode here, and there is going to be direct stimulation of the temporalis muscle fibers, so there will be jaw clenching despite the muscle relaxant. So there should be protection to the teeth should be addressed. So moving on, cognitive issues. These are the biggest, concerns. This is the biggest concern with ECT. In fact, and if there were no cognitive issues, ECT would have been, really well accepted treatment, long ago, and would probably be more widely used. So let's talk about, when we talk about cognition, it's not just again a unitary concept, as far as ECT goes. I want to really see cognitive risks as 4 types. One is the immediate acute effects. Acute effects are really just after the procedure, and there is a general disorientation to time, place, and person, and that usually resolves within 30 to 40 minutes. And the orientation to time is often the slowest to recover. And this is marked in patients receiving bitemporal electrode placement, sine wave stimuli, and which is the older ECT machines, which we don't really have here anymore. And in the Thymatron that you guys use also use square waves, and a higher dose, the higher the dose above the seizure threshold, then you're likely to be more disoriented. So is this, is this important? Yes, it is, because if there is clear longer duration of post-ictal disorientation, it predicts severity of retrograde amnesia after the course of ECT. So if we see this during the course of ECT, then this should be a red flag. And then one has to think about optimizing the ECT to reduce the cognitive side effects, whether that means reducing the pulse width or switch to unilateral, or if the patient's receiving bitemporal brief, then moving them to maybe right unilateral brief or right unilateral ultrabrief might be the way to go. So routine measurement of this is very helpful, and in fact we do this here, and you get a baseline measure, and then do it after every treatment at around 30 to 40 minute mark, and see if there is a worsening during the course of the ECT. So anterograde memory deficits. This is we talk about impairment in acquisition and retention of verbal and non-verbal material during the course of ECT and immediately after the course. So deficits in retention are more marked and often slow to recover. The patients are still able to acquire new information. And anterograde memory function generally returns to pre-ECT levels within 2 weeks after a course of ECT. And once the depression's improved, generally the performance actually improves above the baseline, because the baselines are measured at the time of when a person's depressed. So that's been demonstrated in long-term studies. And retrograde memory deficit, this is often the most concerning, and most dramatized as well in some, in some media. And but it is real. It is a real thing. It does happen. And ECT can cause deficits in retrograde memory for information learned during or prior to the treatment course. And this can be autobiographical in nature or impersonal memory, semantic memory as well. And recent memory is the most effective, and we always see a temporal gradient, don't we, with memory and any sort of event where recent memories are most affected. And although there are certainly reports of patients who've lost memories from years ago, and they generally improve, but with bitemporal ECT, it can persist. It can persist way beyond an acute course of ECT. And non-memory cognition, really, executive function processing speed can be impaired for 3 days after, up to 3 days from a course of ECT. After that, there should be full resolution. And there is really no evidence of any non-memory cognition that persists, other than when when ECT given with sine wave machines, it has been shown that cognition, the reaction times can be impaired even 6 months after the acute course of ECT. This is just a demonstration from a study done by Sackeim. They looked at a number of hospitals in New York, and they really studied the outcomes. As there were no, this was not a trial; it was just more a naturalistic evaluation of outcomes of ECT in different hospitals. Different hospitals were doing different types of ECT, therefore it was easy for them to measure how the outcomes differed in different with different methods of ECT as well. So, as I've said just then, with sine wave bilateral ECT, these are measures of reaction time, and they are worse here at the end of an ECT course compared to other types of ECT. And autobiographical memory as well, it's sort of worse here, and also with bilateral ECT, it's worse compared to right unilateral ECT, where in fact at the end of, in this study, at the end of the course of ECT, it's improved with unilateral ECT. So the same sample at 6 months follow-up. So you're seeing still, there is a deficit in reaction time and sine wave bilateral ECT, and to some extent with pulse bilateral as well. And so the autobiographical memory losses persist, even at 6 months, both for sine wave and pulse bilateral ECTs. So what are the factors that affect cognition? So we've already established some of those, sine wave form in a bilateral electrode placement, and dose in relation to seizure threshold, increased frequency of ECT. So if a patient receives 2 times a week, then they're less likely to have cognitive side effects than a person who receives 3 times a week ECT. We generally do 3 times a week in acute settings, but when it comes to sort of high risk populations, then we reduce the frequency to twice a week during an acute course. And pulse width, we've talked about the effect of pulse width. The narrower the pulse width, the better the cognitive side effects. And longer courses definitely cause more side effects, and therefore maintenance ECT as well, might be a situation where one might look at having more possibility of experiencing more side effects cognitively. So patient factors, you've got older age, older the age, then you're likely to have a lesser cognitive reserve, and and therefore more likelihood of cognitive problems. Baseline cognitive scores being low, even in a situation of severe dementia, they might still be at risk of having more cognitive effects from side effects from ECT. A patient with a history of head injury or any neurodevelopmental disorder or other cognitive abnormality. Concomitant lithium use is a risk factor. It's definitely been associated with post ECT delirium, and we would generally advise either to discontinue lithium if we can. If not, then at least skip the dose of lithium the night before and the morning of ECT. So we know cognition's a concern and an issue. So what do we do? Do we test? And if so, what are we going to gain from testing? How do we test? So these are all the questions really. So deciding on what domains of cognition to test, and what to test, and what tests to use, and when to measure it. What is the right time to test? Is it just before ECT, after ECT, the day after ECT, or the evening of ECT? So there are lots of questions we still don't have clear answers for. And what could be the utility of it? Could it predict functional outcomes? Could it help reduce the cognitive impairment? Should we be able to measure them? Can we provide some cognitive mediation for patients who have cognitive impairment? Are there other therapies we can use, like cholinesterase inhibitors have been shown to have some beneficial effects? And so does it, testing cognition, does it improve patient satisfaction with ECT? Will patients feel that we're taking their concerns seriously, and really, being rigorous in our approach to it? And does it all correlate, with subjective cognitive complaints that or problems that patient experiences? And what are the, does it help in medical legal situations? And the important thing is feasibility. In a busy practice, do we have the time, to sit and do detailed cognitive assessments? Does everyone have expertise? If a psychiatrist can't do it, can nurses do it? Can another allied health person do it? And what is the cost of it? Where do we do it? Do it in an ECT setting? Is there going to be a quiet environment where the patient can be tested? All those things. So what is the best way to do it? We don't know a lot, but I think the current consensus, if we look at what's been written on this, is that so we don't do all of this, I must admit, even in our sort of practice here. What we do is we do a baseline cognitive measure, global cognitive measure like MOCA, Montreal Cognitive Assessment, or TRIMS, and we do that at the end of the course, and then perhaps after a month. Particularly that's helpful in patients who have had deficits after the course of ECT. And it would be important to check orientation after each ECT, 30 to 40 minutes after the ECT, and to compare those scores. And you have to do one before the start of the ECT. And as I said before, if there is a deterioration in orientation, time to reorientation, then that predicts retrograde amnesia. So then there is a potential for us to intervene during the course of ECT rather than just waiting for the course to end and going, oh, this person's ended up with a lot of cognitive problems. And there is another screen developed by Professor Colin Lewis' team, brief ECT cognitive screen, which is a very simple test. Only takes 3 to 4 minutes to do, really, which can be done at baseline and after the third or fourth treatment, the day after their third or fourth treatment, or on the same day. And then if there is a difference in scores between the baseline and the third and the fourth treatment, then that person might be at risk of experiencing more anterograde problems. And again, gives us an opportunity to intervene with things that we can manipulate, electric placement, pulse width, etc. And there is an autobiographical memory inventory from the Columbia University. There is a short form which can take up to, depends between 20 to 30 minutes, or sometimes an hour. That can be used to sort of assess, get a baseline measure of autobiographical memory, and then that will be used in sort of subsequent assessments during the course. If we are time poor, simple questions like, has ECT hurt you or helped you? A positive or a negative response to that often tends to correlate with objective scores for retrograde amnesia. So, simple things like that might be even helpful. This is just a summary of various screening instruments designed for ECT. I won't go through this in full detail. And this is just we have general sort of existing cognitive screens that could have some role in assessing patients undergoing ECT. So this is a sample of the brief ECT cognitive screen. So basically two tests. The first test is count backwards from 20 to 1 as fast as you can. So you're measuring time and mistakes, errors, and then say the months of the year starting from December, going backwards as fast as you can. So you're testing again errors and time. So you're doing the same test after the day after the third or the fourth ECT, seeing if there are any, and again, errors in time. And if there are more errors and if they're slow after the third or the fourth ECT, then you get a positive difference here. And then each positive difference, there is a sort of a scoring pattern, and it's out of 5. So the lower the score, the better. And if somebody scores, let's say, 0, and then that's fine. I mean, it's they're unlikely to have any anterograde memory issues, or less likely. But if there is a higher score, then you would have to be concerned. And this is a sort of a standard orientation questions which we tend to use: name, date of birth, current prime minister, former prime minister. This can be really modified to your own sort of setting. So these are essentially the treatment decisions when it comes to ECT, the prescribing of the treatment decisions. So what electrode placement are we going to use? What pulse width are we going to use? How are we going to dose it? Deva mentioned that you dose using age method, and the frequency of the ECT itself, whether it's 2 times a week or 3 times a week, and medications during and after ECT. That'll be a consideration. So the dosing strategies, age-based method is what you're familiar with, which is I think you use half the age for bitemporal or bilateral ECT, and the same age for unilateral ECT. Is that right, Deva? Is that how you do it?
I did hear it. Sorry?
No, I was just asking, age-based, do you use half the
yeah, that's
for,
right. Yes.
Bilateral, and for unilateral you use the actual age itself, right? And dosing.
Actually, we hardly use unilateral, Jyoti. Most of the time, it is bilateral that we use. I don't think any of the units. Yeah, bitemporal. Yeah.
Yeah. Okay. Excellent. So I think that's really the age. The advantage to the age-based method is that one, you're not titrating. You know, if you have an acute situation, there is a chance that you might not get to even the threshold on the first treatment. You know, particularly a patient's threshold is high, and so there could be a session that's totally wasted, if you like, and that time can be valuable for someone in a very critical situation.
That's true.
So I think that's one of the advantages, and the second advantage is with titration, subconvulsive stimulus of ECT is associated with asystole and bradycardia, because you're not the stimulus induced asystole is not followed by the sympathetic surge that you get with the seizure. So it can be there is a risk of prolonged bradycardia during titration. So that is another sort of consideration, and that is one of the advantages of the age-based method. And the other is that there is good evidence to say that the age-based method correlates reasonably well, with titration methods as well. So I mean, there is absolutely nothing wrong with the age-based method, but it's titration is a more foolproof way of knowing what exactly a person needs, and with age-based, you're still you could be at a situation, particularly with bilateral, where you might be over-treating a given patient. Under-treatment is not an issue with bilateral, because even threshold or just supra-threshold doses are adequate. As we saw, that low-dose bilateral is perfectly effective. So it's not an issue when you. The only issue really is over-treatment or overdosing in some individuals. And perhaps that can be monitored, and the dose can be reduced after subsequent treatments. And fixed doses, you're just giving the same dose for everyone, really, and that's I don't think that's really acceptable anymore. Okay, so these are just the examples of dosing charts that we use. So this is for brief pulse. So what we tend to do here is in a unilateral electrode placement generally has a lower threshold than bilateral electrode placement. So if it's a female, they have lower thresholds, and they then have higher thresholds. So these are the starting points. So if it's a male having bilateral, we start with 15% on the thymatron, and that will be the starting point for titration. On the first session of ECT, we will start here and then keep going up every if there is no seizure response, and we'll go to 25. There is no seizure response, so we'll go to 35, right? And we would do up to 4 stimuli in the first session, first titration session, and then we'll stop. We won't keep going after that. We'll go back to the next. We'll really send the patient and continue the next setting. And it's rare. It's rare that you will not get a threshold in the first session itself. And what we would do is that after 3 stimuli, if there is no response, we will skip a step and go to 70 instead, because if you don't want the whole session to be wasted. So if we get a threshold, if we get a seizure at 70, the next time around, then we will actually start at 50 to see if the threshold was any lower than 70, because we skipped that step to really get still get an accurate sort of estimation of the threshold. So this is the sort of the threshold. This is the chart that we use for brief pulse, and this is the one we use for Ultrabrief. Ultrabrief, as I said before, it's a very energy efficient stimulus. So we start at 2%, and for men and women, unilateral is what we use. Bilateral, Ultrabrief is ineffective, so we don't actually use that. And so go from 2, 4, 8, 15, and the treatment dose is 6 times that. So 15 times 6 is 90. So this is what we would treat at the subsequent sessions. So I've just talked about this, really just then, and so we talked about the titration itself and what to do when there is no threshold after 3. We skip a step, and once you've determined the threshold, then you really chart the treatment dose for unilateral brief pulse. One has to treat the patient, at least 3 times, if not up to 6 times, really. So, say it's approximately 5 times. That's sort of what's commonly used for it to be very effective. And again, it depends on the type of patient you have. If you have really an older person with sort of mild cognitive impairment, then you might, only start at 3 times. If you're still using a brief pulse with unilateral electrode placement, and see how they go, and if there is any lack of response, then you might increase the dose later on. With bilateral, we can treat at 1.5 times cessation threshold, and there's a high dose bilateral 2 to 2.5 times. This is particularly relevant when a patient doesn't respond to low dose bilateral, or when you reduce the pulse width from 1 millisecond to 0.5, then you might really have to increase the dose to these levels, even up to 3 times the cessation threshold to make it effective. So the medications during ECT, really, the first thing to do is, the patient's already tried antidepressants, been on maintenance antidepressant before with a recurrent depression, and still developed, relapse or a recurrence, rather, then, well, there's no point in continuing an antidepressant that hasn't done what it should do. So discontinue antidepressant and really plan for the next sort of pharmacotherapeutic step. And mood stabilizers, really, if somebody has been on a mood stabilizer mainly for major depression, even in a unipolar context, used as an augmentation agent, for example, lamotrigine, then you would still stop that during the course of ECT, and plan for post ECT pharmacotherapy and start them on something, so you can get them up to a decent dosage by the time they stop ECT, and so there is adequate cover by then. And the medications that ought to be continued are, they're sort of medications that they need for the other comorbidities, antihypertensive, steroids, reflux agents, anti-anginals, antiarrhythmics. So they should be, really given with a sip of water, a few hours before the ECT, first thing in the morning. And it's particularly important to have antihypertensives and antiarrhythmics, because of the cardiovascular effects of ECT. And bronchodilator should be continued. IROF for any glaucoma and other conditions should be continued. Theophylline and bupropion we should try and avoid it, because they can reduce seizure threshold. The reports of status when used in combination with when these medications have been continued with ECT. And cholinesterase inhibitors, if the patients are on it for any dementia, or even if you're using it as a cognitive enhancer for someone with ECT, undergoing ECT, and you really have to think about the risk of bradycardia more carefully, because if the cholinesterase inhibitors will potentiate that, and they also increase the, I think it's galantamine, if I'm remembering right, it also increases the duration of action of the succinylphonium, because of they have sort of, I think they share the enzyme that metabolize the muscle relaxant. So diabetic drugs should be avoided, like particularly until the ECT is done in the morning, and it should be discussed with the endocrinologist closely. And as the depression improves, there might be also a shift in the glycemic control and status, and it might actually improve. So the blood sugar measurements and the hypoglycemic drug doses has to be continuously reviewed closely. As I said before, lithium, we should try not to use it, but if it is a situation of bipolar disorder, where there is a high risk of manic switch in a particular patient, then if you decide to continue lithium during the course, at least skip the dose the night before and until after the ECT is given the next day morning. So at least the serum levels will be lower, and the higher the serum levels, so there is a correlation with the incidence of post-ECT delirium. And avoiding benzodiazepines and anticonvulsants are important, mainly because of their effect on seizure threshold, and also it affects the EEG as well. When we see the seizures on EEG, they're sort of very low amplitude, poorly differentiated as well. So often patients end up requiring very high doses of ECT, and that might contribute to cognitive problems. And in the bipolar patient, as we talked about just then, one has to decide, whether it is safe to continue or discontinue the mood stabilizer, particularly because there is, if there is the risk of a manic switch, then you might have to continue at sort of reduced doses. And a similar approach to epilepsy as well. We would, if you're going to continue the dose, then we should skip the doses the night before. Cardiac pacemakers and defibrillators, they're not an issue with most newly manufactured products, but we always, as a routine, just have a chat with the cardiologist or even the manufacturer, really to make sure that we don't have to do anything different. So moving on, EEG and ECT. It's a really EEG monitoring in ECT. I understand that's not something that's a routine practice. David was telling me before the talk. So what's a reason to do it? It's a reliable measure of really presence of seizure in the absence of motor seizure. That can happen particularly in patients who are very sensitive to muscle relaxants, and I've seen patients quite a number of times where there's hardly muscle seizure, motor seizure, but you would see a very beautiful EEG seizure, very typical of the seizure activity. So in those cases, you simply just continue the dose. Really, you wouldn't predict it as an absent missed seizure. So if you don't have that, then there is a risk of misinterpreting it. But you can get over that by using what's called a Coughlin method, where you sort of use a BP cuff and increase the pressure to above systolic blood pressures, and before the muscle relaxants administered, so that limb is isolated, and you can see the motor activity there, which is not affected by the muscle relaxant. And obviously, it helps with more accurate dose titration, and it helps identify whether a person's having prolonged seizures. And motor seizures typically are shorter than the EEG seizures. EEG seizures tend to go a lot longer than the motor seizures. And identify status in patients when that occurs. Unfortunately, it's a very rare complication. And really, when you identify these things, these things can be appropriately managed and not missed. And the other most important aspect to it is that there are EEG parameters and morphology that can help determine the adequacy of the treatment, whether a treatment is likely to be effective or not. So we'll talk about a typical EEG and tracing during ECT. So we would first take a baseline, and then the machine will automatically run. But once the stimulus is given and the seizure starts, or even without a seizure, the EEG will start printing. So you would see 5 phases. Really, phase 1 is this is where the stimulus gets given. There is a sort of a sharp spike and a uptick here, and then there will be a really in a low amplitude, fast activity for a short period of time. This is what we call the electrode decremental period. And phase 2 is when you start to see poly spikes. So around here, where you start to see some poly spikes here, and this coincides with the sort of early clonic phase, and can last around 30 seconds or so. These phases are not sort of not the same in all patients, it can sort of blur, and one phase can blur into another. As you can see here, there is a bit of a spike in slow wave activity happening at the same time. And the third phase is the slow waves. This is a beautiful sort of representation of slow waves, theta and delta waves, and they will sort of start and pick up in amplitude and reach a maximum amplitude sort of midway, and then the amplitude will drop around here as it's sort of starting to drop here. And so for phase 4 is the seizure termination, where the seizure comes to an end. So you see that the seizure is coming to an end here. So it's sort of more or less sort of, you can see that it sort of ends around here. There is sort of low amplitude, slow waves still happening as one here, but sort of ends more or less around here. But then it can be a bit difficult to determine in some other situations where there is a very progressive, loss of amplitude, and it never really sort of fully flattens. There's still a little bit of activity here. And phase 5 is a post-ictal suppression, which is in comparison to the baseline where you see no electrical activity at all. So this is a baseline. This is before the stimulus was given, and you can see that there's clear suppression. There's only sort of flattening. And whereas here it's not so much. There's a little bit of deflections there, which might be a low amplitude slow wave. So what do we do with the EEG? How do we interpret it? And so we're really looking at certain aspects of the EEG and seeing how they are in a particular patient during the course of ECT, whether there is change. So every patient EEG can be very different. So there is no particular standard that we are aiming each patient's EEG to look like. So really, what we're looking for is over the course of ECT, if there is a deterioration in certain morphological characteristics suggesting a decline in the quality of the EEG, and they really are the recruitment time, the time it takes for the electrodecremental period to pick up into poly spikes, which represents the time it takes for the stimulus to recruit enough neurons, and mid-ictal spike and wave activity, the amplitude, and the wave coherence on both the hemispheres. So we have two on the strip I showed you. There's two channels. One usually the general convention is the lead 1 is left of the dominant hemisphere, and lead 2 is the non-dominant right hemisphere. So there's a good coherence on both on both hemispheres. And then you have you look at the termination of seizures, whether there is a progressive slowing or whether there's an abrupt sort of suppression of seizure activity. Now, abrupt suppression is suggestive of a better ECT treatment as opposed to a slow progressive loss of amplitude. And post-ictal suppression, how well the EEG suppressed after the seizure itself. That really reflects the refractory period that the neurons get into after a seizure. And in a machine like the Timatron in particular, they give it gives a printout, and in the end of the printout you have various automated indices that represent these aspects of the seizure. But the trouble is in it, there is a number that you get, and there is we don't clearly know other than post-ictal suppression index in a way, above 75% means a good sort of seizure. We don't really know how well the other numbers, whether there is a cutoff point when one can aim for. There's the clinical utility of it is not all that well established. So, as I said before, there are inter-individual variation in EEG, and particularly with age. Older adults, the EEG, you see that the amplitude is small, and there will be sort of less duration of PCT, the EEG, the duration of seizure as well. But duration of seizure doesn't necessarily correlate well with anything really, but we measure that religiously through convention more than anything else. And these other sort of EEG morphological features, they have no value than the duration itself. Although most clinical guidelines will say aim for at least 25 seconds of EEG seizure for it to be an adequate seizure, and the motor seizure for 15 seconds. So does EEG predict outcomes? There are a variety of measures, including the ones that I've mentioned in the previous slide, are associated with positive clinical outcomes, but the strength of the relationship is not particularly significant. There's no clear idea as to, they're all sort of small associations, small relationships, and how that can be translated to improving clinical outcomes is not clear. And other factors can also affect the EEG, really. So in the same patient, if you're going to use bilateral electrode placement and with a wider pulse width, which with a much higher dose above the seizure threshold, they will have a much more robust response on the EEG as opposed to someone with Ultrabrief, unilateral, a bit sort of closer to the seizure threshold. So there is an aspect from the stimulus itself that will determine the EEG output. So we know that the seizure threshold can increase during the course of PCT, and that has to be managed, particularly in a patient who is receiving unilateral ECT. Because if the seizure threshold keeps increasing, the dose that you started with initially might not be still 5 times the seizure threshold. It might have gone lower than that, therefore reducing the effectiveness of it. So the seizure threshold rises in about 50%, and is associated with lower likelihood of response. And with unilateral ECG, we know that the ictal EEG deterioration and quality was associated with raising seizure threshold. This is where it perhaps has the most utility in EEG monitoring. And recently, Galvez et al. She demonstrated, their groups demonstrated with unilateral Ultrabrief ECT patients that rise in seizure threshold was associated with mid-ictal amplitude reduction. And in an older study, Crystal, she had demonstrated that she was able to predict based on an EEG from a second ECT in a course whether a person would respond or not, without a further increase in dose. So where she expected a person to have an increase, and when they didn't have an increase, that group of patients only had a 47% response rate, as opposed to the group where she, where the EEG was actually okay at second treatment, or they in fact had a dose increase. The response rates were much higher. So it's pretty significant as far as delivering adequate ECT treatments. So number of ECT is it's really variable from person to person, but most patients receiving bilateral ECT will improve by 4 to 6 treatments, and similarly right unilateral brief pulse, they would also start to show some improvement by then. Unilateral ultrabrief ECT can be slow to act. It can take sometimes up to 8 treatments to start to see some improvement. So you might want to hang on to those patients a bit longer before considering a switch to other electrode placements or pulse widths. And this is not the case though in RCTs. In RCTs, they didn't find that the speed of response was any slower with ultrabrief ECT. But in real world setting, it doesn't really tell the same story. So when to stop ECT, that can be a difficult decision, particularly for someone who's not improving. For someone who's improving, really once they maintain remission for a week, or if their improvement plateaus for a week, then you sort of stop ECT at that point. But for someone who's not improving, then you can, if the diagnostic certainty is there, then there is good reason to continue ECT beyond even certain number of treatments, 12 treatments. I've certainly had patients, with other comorbidity. Older patients with vascular comorbidity can take a lot more treatments to get better cerebrovascular changes, and their brain can reduce their ability to improve faster. So some patients have needed 17, 18 treatments before they actually start to show signs of improvement. So post ECT pharmacotherapy, these are the sort of standard, sort of established sort of treatments that work better. Continuation ECT, these are the sort of indications really for continuation ECT, where there's a clear response to acute cause, there's recurrent and severe illness, intolerance to medications, and patient preference, rapid cycling bipolar, and treatment-resistant schizophrenia, where they actually will need to stay on longer-term treatment. Acute cause often is not enough for a patient with treatment-resistant schizophrenia. So there are different schedules. I can see that really over time now, an hour and 30 minutes or so. Do you want me to quickly go through the maintenance ECT aspect, Deva?
Yeah, I think, yes, please.
Yeah. So the different schedules for maintenance ECT or continuation ECT really is the first 6 months after an acute course. There is a slow transition where you would do weekly ECT for 4 weeks, and then fortnightly for a couple of months, and then move to monthly for the up to 6 months, and then decide whether you still continue monthly or not. That will become the maintenance treatment. And fast transition where there is a first session after the first week after the acute course, and one more in 2 weeks, and the third in another 3 weeks after that, and then move on to monthly. But it's important to maintain flexibility to prevent relapse, reduce cognitive side effects. It's not sensible to religiously adhere to any one of these protocols, particularly with patients with bipolar disorder, where they might switch. What do you do then? There is this sort of stable, protocol, which is symptom titrated algorithm based longitudinal ECT. So where after an acute course, a patient gets 4 treatments in the first 4 weeks, on a weekly basis. And from there on, they are having regular assessments with HAM-D scores. And depending on the HAM-D scores, particularly when the symptoms get higher or continues to get worse over a period of a couple of weeks, they determine, whether they get no treatment at all that week, or 1 treatment that week, or 2 treatments that week. So it's basically titrated to the symptom on a week-by-week basis up to 6 months. And this was really evaluated in older patients, actually, in over 65s, in a study, PRIDE phase 2 study, where they randomized after a positive response to right unilateral Ultrabrief ECT. Patients were randomized to either lithium and venlafaxine or continuation ECT plus lithium and venlafaxine. What they found was there was less relapse, and time to relapse was longer, and the HAM-D scores was much lower with the continuation ECT group. And more importantly, what was interesting was that 35% of patients in this group actually needed at least 1 ECT during that sort of flexible phase where they with the stable algorithm. And out of the 21 patients who had the stable algorithm, only 3 patients relapsed, despite that additional ECTs they've had. And these ECTs were called rescue ECTs when rescue a patient from worsening depression. They were always associated with significant drops in HAM-D scores after that week. So there is some acute effects when there is a worsening in that sort of phase of the illness. So mechanism of action, look, I mean, there is a whole host of neurophysiological changes, neurochemical, neuroplastic changes. This is something, very useful. I might just mention this before I stop. There is this notion that ECT actually kills the brain, fries the brain, all sorts of things. But in fact, there are studies that actually show that ECT increases hippocampal volumes and increases amygdala volumes and increases the functional connectivity of hippocampus and overall sort of functional connectivity in the default mode networks. So really, that is that sort of idea has no truth, and I would often say this to patients who have such concerns. So really, there's no uniform theory of mechanism of action. There are sort of lots of different findings. We don't quite know what mediates the therapeutic response and what's the phenomena just from the treatment itself. And it's helpful to share with our patients what ECT, what all effects it can have, so they know that it's not through other sort of previously thought of hypothesis like psychological, where they felt that punishment was ECT was seen as a punishment, and therefore some of the patients got better. So I might just leave it there and take questions if there is any, or elaborate on things if there is any.
Thank you very much, Jyoti, for that comprehensive lecture. I think our trainees especially, they might have a lot of questions. This is the time for questions. Please take this opportunity to clarify your doubt.
Hello.
Yes.
Yeah, go
Hello.
ahead.
Sir, what is the consensus on continuing clozapine before ECT?
Look, I mean, clozapine has been established as a safe a combination with ECT, and if anything, in patients, the main risk you are concerned about is the clozapine and its seizure lowering effects, and second is the aspect of the cardiac. Some patients on clozapine can have tachycardia. So and that can be exaggerated during the ECT. So really a management of that. So they're the concerns, and there is no real evidence for any sort of high prevalence of status or any higher incidence of cardiac complications with ECT. But like anything, there has to be a close discussion with the anesthetic team about a patient if they particularly are tachycardic when they're on clozapine, and really so they can manage that with some rate controlling drugs during the procedure. And there are synergistic effects with continuing clozapine or any antipsychotic for that matter with ECT in terms of improving the psychotic symptoms.
Thank you, sir.
And Jyoti, you were talking about the positioning of a pregnant woman. How should we position the pregnant mother?
Look, I think there are different different things mentioned in the literature. I have not had any clinical experience in actually administering ECT to any patients during their pregnancy. So the things that have been talked about are using a wedge under the woman's hip to tilt the pelvis at an angle such that the fetal circulation is improved. And there is another mention about a patient being turned to the left side, and so I think this is these sorts of specific positioning of patients probably should be always done with consultation with the obstetrician. And there are a couple of articles that are there on this particular topic, which I can share with you if you want to know a bit more in detail.
Yeah, please. Yeah, that would be, yes. Any other questions from the audience?
Yes, I'm Naina here. Dr. Jyoti, I want to clarify that we do consider first line as first line in acute psychosis, and when it comes to kind of first episode psychosis, kind of what are the kind of neuroimaging kind of mandatory ones we do need to carry out before ECT?
Yeah, look, neuroimaging before ECT is, neuroimaging is two sorts of implications, isn't it? One is really the diagnostic aspect. If you've got somebody with first episode psychosis, there is another organic etiology. Whether there is a possibility of any NMDA receptor encephalitis, or any autoimmune encephalitis could explain the psychosis in a young person. So that's one aspect to it, and the other aspect is the whether there are any other issues that you might want to know in terms of the safe administration of ECT, and things like whether there's any intracranial mass or intracranial aneurysm, and look, we generally here access to CT brain is readily available, right? And so, nearly all the patients who present with first episode psychosis will have a CT brain within within a few days of hospitalization. So that that is often adequate, but again, if clinically, if somebody looks like they have other features, other sort of neurological features, or even sort of catatonia, or any other features that might suggest other organic causation, then you might want to explore a bit more with the MRI. But it depends on whether it's what the availability and access you have to neuroimaging, and to your clinical index of suspicion around other risks, and that would be another thing to consider.
Okay, thank you so much. It is really important for us. We have got kind of ECT really available most of the times, but MRI we have to kind of wait, and if it is urgently required, so we can get down from a major hospital. So thank you so much for this information. Thank you.
Sir, hello.
Yes. Hi.
Foreign bodies in the brain, such as bullets, that such foreign bodies, is it an in contraindication for giving ECT, sir?
Look, it would be a high risk, and because there will be, when you're passing an electrical stimulus in a person with lodged metal objects, and then then there is a likelihood that if there is a if that goes through that region of the brain where the metal objects are lodged, then there could be a heating of that of that metal object, and there can be therefore localized inflammation and complications from that. So you have to be really careful about those situations. One really establishing that there is an absolute need for ECT, and that there are no other safer treatment options. Two, when you do proceed towards ECT, you really want to know the exact location and manipulate your electrode placement and pulse width, perhaps, to reduce the electrical field, to much, and keep it much further away from from the foreign body that you've identified. So that you have to, it will be a very sort of improvised sort of ECT, with a very unusual electrode placement and a sort of and a pulse width that you might use in that sort of setting.
Okay, thank you very much.
It's similar to if people have any sort of skull plates, if they have any head injury and had any sort of skull plates, you can do it, but you're going to really modify the procedure. So so it's sort of it's much further away from that.
Okay, thank you.
This is Gihan here. Thank you very much, Dr. Jyoti Ramalingam, for that very informative presentation. I think it really helped us to refresh and update our knowledge on ECT. I have a very brief question about continuation or maintenance ECT, which is not much practiced here in Sri Lanka, but I also don't have much experience in this. Now, we have this one particular patient who has been, is a treatment-resistant schizophrenic patient who has been quite violent and who has murdered another patient inside the ward. And she has unprovoked aggression towards staff and other patients in the ward. So we have a big problem of her placement. And she's on high dose of clozapine and augmentation, other agents. We have tried so many amisapride typicals, and now she's only maintained on, she's controlled only on maintenance ECT. So initially we started with weekly maintenance ECT when we went up to 2 months, and then started fortnightly. But as soon as we start fortnightly, she relapses and gets violent, assaults the brother, and quite violent towards other patients and other staff members in the ward. So we had to revert back to weekly ECT. So now we have a dilemma here. How long can we go on with this weekly ECT? I think it's not advisable to go on like this forever with weekly ECT. Any idea on, because pharmacotherapy doesn't work well, and we are not much sure of her compliance as well as soon as she gets out of the hospital. But even inside the hospital, we find it difficult to give her a fortnightly.
It sounds like a very treatment-resistant patient who carries a high risk of assaulting others, and this is with continuation ECT, generally you phase towards weekly, fortnightly, and then move to monthly, really. And how many how many weekly sessions has she had roughly? How long has this been going on? So a few months, no?
Now for this current episode, it's we have given weekly for 6 weeks, I think. Now, yes, it's 6 weeks.
Weekly for 6 weeks. Okay. Look, I would. Sorry.
Yeah, as soon as we go on to fortnightly, she gets quite violent towards in between ECTs. So and then the staff gets quite agitated, and then all keep on asking for us to go back to weekly ECT inside the ward, and she has been in our ward for months now.
Okay. And if it is if it is 6 weeks of weekly ECT now, I would probably continue that because she's an exceptional patient in the sense of treatment resistance and aggression. So there are some patients who need more frequent and longer courses of ECT, and there are some patients who have been on continuation and then maintenance ECT for years, really, particularly with schizophrenia. When you see positive effect, then you are really in it for the long haul, and even to stop it after a few months might not be feasible without making the condition recur. So if you've done weekly for the last 6 weeks, I would probably continue weekly ECT for another 4 to 6 weeks, and then gradually try and taper it, even to move to 10 days sessions if 2 weeks wasn't helpful, 2 weeks wasn't possible last time around. 10 days, and just see if that she's able to maintain her wellness, and really each step of the way I would do it after 6 or 7 treatments in that sort of pace. So you've done 6 weeks of weekly, continue that to another 6 weeks, and the next phase would be 10 days of 10 days between treatments for another 4 to 6 sessions, and then phase it out perhaps to 2 weekly, and then gradually progress. But you might be looking at a situation where this person's going to need long-term treatment, long-term as in for a few years at least.
Yeah, so what is recommended is now what you told in your presentation is switch on to fortnightly for 1 month and then to monthly for 6 months, is it?
Yeah. So that's there are some standard protocols, that we used to use. Now it's really, I think, there is a risk of over treatment, under treatment, with standard protocols. So I think the stable algorithm, that's mainly for depression, where there is a symptom-based titration. But I think that makes sense. I think in really what you're doing in her case is also a symptom-based approach to treatment. But it's just that we feel uncomfortable because of the number of ECT that she might need and how frequent she might need the treatment. But there are outliers. And that's
Will there be major risks of giving her fortnightly ECTs long term for about a few months?
Look, the risks are mainly going to be with memory. She's, I'm assuming she's having bilateral ECT and with brief pulse. So the retrograde amnesia, is going to be an issue. She might manifest more problems, going further. That will be the main concern. But there are, no other sort of, concerns other than the cognitive issues that you might see. And there is often a tipping point, where you might start to see more, after a certain number of treatments, whenever that happens to a given individual. Then you might, want to just, pull back on the frequency of ECT.
Okay, thank you very much.
I'm sure there are a lot of questions from the audience, but now we have taken about 2.5 hours from Jyoti's Sunday afternoon. Shall we then end it? Gihan, what do you think?
I think Dr. Ramalingam was initially prepared to do it for 1.5 hours. I think he has exceeded his time much more than that. So we'll make it a delay.
Yeah. And thank you very much, Dr. Jyoti Ramalingam, for doing this lecture, a very comprehensive one. And also, we haven't had a lecture on ECT, I think, for last 2 or 3 years. So this was very refreshing, and then added a lot of new knowledge. And I think we can contact you if we want to change our practices and need some practical advices on that.
Yeah, of course, Deva. Yeah, anytime.
Yeah, okay. Yeah, thank you very much. And on behalf of the college, again, I would like to thank you for doing this lecture.
Thank you. Thanks for the opportunity, Deva and Dr. Jihan.
Thank you very much again, Dr. Ramalingam, and of course, Dr. Devasmika Arisinghe for initiating and organizing this, which was really good and very refreshing to refresh our knowledge and update our knowledge on ECT. And your support towards the Sri Lanka College of Psychiatry is greatly appreciated. Thank you very much.
Thank you. Bye now.
Okay, bye.